Okay, so we have almost right now more than 42, 43 candidates. So without wasting further time, okay, there will be people who will be logging in and leaving out. Okay, so good evening, everybody. It's a privilege to host all of the young intensivists who are the boarding critical care specialist in India as well as abroad, and who would be doing a great work for our nation as well as for the global level. So I would be starting with the introduction of my course director as well as the faculties. Myself, I am Dr. Tapas Kumar Sahu. I am intensivist from Medanta Hospital, Ranchi, and myself is the course director for this one. Along with me, my co-course director, Dr. Sanant Kumar Das. Dr. Sanant, could you please give 10-second introduction?
Yeah, hello everyone. My name is Sanant Das. I work as an intensivist in Australia in Queensland. Basically, I have been trained in India and also in Australia. And the people who have already enrolled to this course already know about the course structure and everything, but who are new to this course, this is a effort from our side to ease out your journey to pass the exam, whether it is the DM in critical care or whether it is the DNB or whether other fellowship exit exam. So we have two series of Viva practice. This is the first one, which we try to simulate the actual fellowship or actual DM practical exam, which consists of the long case, the table viva, the critical evaluation of a medical literature, and also communication part. Though those exam are face to face, but in this era of new digital education, so we try to simulate most of it, and we try to be as close to as the real exam scenario. Now, Tapas, shall I go quickly through the course?
I'll be just like maybe for 2 minutes. 2 minutes, I will be. Yeah, Dr. Sanand, thank you. I would be just requesting you to start maybe in 1 to 2 minutes. So before starting with this novel initiative, I would be sharing the problem which we faced during our fellowship days, because that is very important. In our DNB days, when I was doing my DNB from Sir Gangaram Hospital, and after that when I was doing my fellowship in Toronto, so definitely there were no specific, you can say, training courses which can guide us. What are the things we can have in our training period, or at least one can teach us the small tips and tricks that should help us in doing good job and clear our exams. So that's the way we thought maybe we'll do something great for our own students as well as our own colleagues. And the reason with which we started this 360 critical care, as well as we started with all the training courses for EDIC 1, EDIC 2, as well as our own national exam, that is DM DNB, as well as IDCCM, as well as IFCCM. So this is the concept to make you ready to face the S. And with that background, we are right now with the biggest brainstorming session of the year, where we would be having two simulated mock tests, comprehensive discussion sessions by the national teachers, and also we would be making you realize how the questions start, how the examiner wants the examinees to discuss the cases, then the table vivas, then also the communication, critical appraisal one by one. And that is bringing the on-site exam to the online, because we cannot reach, or all the candidates cannot come to one center to learn these things maybe in short time. So definitely we are coming with that, with a proper plan and unique and innovative idea. So that's the concept with which we started, and we are getting a great response. Thank you all of you for attending, and good evening, sir. Dr. Babu Abram, sir.
Yeah, good evening. Can you hear me?
Yes, sir. Yes, sir. Very well, sir. So with us today, we have very eminent national and internationally renowned examiner as well as teacher. We all know him. So Dr. Babu Abram sir from Apollo Hospital, Chennai. And with us also Dr. J.V. Divatia sir. Again, he needs no introduction. Very renowned and revered teacher at the national level. We have been all trained from him only. So with these two national examiners, we have also Dr. Santanu Bakchi. Dr. Santanu, he is the consultant critical care from the Tata Medical Hospital, Kolkata. And also we have Dr. Biswabikas Mahanti. He has been again trained in Singapore. Before that, he has FNB from Indraprastha Apollo Hospital, New Delhi. So with that, we would be starting with the idea of advising tips, assistance, guidance, support, and help to all the examinees. And good luck. And we will start with Dr. Sanant. You would be starting with the two long cases one by one. And then we would be again, like as the real examination happens, we would be taking help from our the examiners, our mentors, how the examinee should have done, or what are the other things one should keep in mind that can help them to score more or better in the real exam. So Babu Abram sir, these are the things we will be going one by one. So, and I would be moderating and requesting you to share your own thoughts.
Yeah, not a problem.
Yeah, okay. Dr. Sanant, I am stopping my screen. Yeah.
All right, thanks.
And in the meantime, you have the candidates, any queries, please post in the chat box. We would be happy to answer this during the the course of our the today's evening program. And also after that, also in our WhatsApp group, we would be also trying to help you.
Right. So, good evening again. So, how the course or how the session will run is I will go through a case, like a long case. So I will read out the scenario, and then after that there will be a short video, around 2.5 or 3 minutes video, to show you the case, the findings in the case, and the viva will run afterwards. That's how the usual exam happens. So they will give you a stem to start with and ask you to examine the patient. So usually it depends on the type of exam, how much time you get for examination, and the center where you are appearing the exam. So I think in this case, you'll get around 10 to 15 minutes to examine the case, and then get another 2 or 3 minutes to gather your thought and then face the examiner. So similar way, we'll start with a stem, and then I will run the video for 2-3 minutes, whatever the video is for. And then after that, after 2 minutes of that video, then we can start the viva, how it can happen in the exam. This is the first of the case, and the second case will be done by Shantanu in a similar pattern. But as it is just as a debrief, so I would request the faculties, if they can jump in anytime, to put in their input in it, what extra cases or what extra things can be asked in the exam, and how do we approach. Definitely at the end of the case there will be a discussion among ourselves, but in between, if they think there is something to be added on to the discussion, please step in there. Okay, without getting more delayed, let's start the proceeding. So this is the first case. Usually in the exam you get the long case as a good chunk of marks. So as a default, if you pass both the long case, usually you pass the exam. So that's how it runs. So this is a 57-year-old male who has been in the ICU for 10 days now. He is currently tracheostomized and is on a high flow oxygen through the tracheostomy. He has a background history of CA pharynx with involvement and necrosis of posterior wall of the hypopharynx, larynx, and posterior wall of the cricoid with cricoid to esophageal fistula. He had a critically narrowed laryngeal inlet, which scored him a tracheostomy. He has lost around 35 kilos over the last 5 weeks in terms of body weight, with repeated hospitalization with ongoing chemotherapy for his CA pharynx. His current hospital admission is due to persistent cough and intermittent fever with progressive shortness of breath. He was treated with meropenem and teicoplanin for aspiration pneumonitis. The question is to examine the patient and enumerate his current issue. So I'll run the video after this to show you the patient details of the findings in him. That's basically the findings of this case, which we will talk about. Going back to the questions. So usually in the exam, you'll come across such a case where you'll get a stem as we described, and then you will have a bunch of finding there, which may be fitting with the case, which may be combination of few other pathologies. And it's very sometimes it is very hard to put every finding into perspective. But if we see something like burning finding, you expect a question about it. Like for in this patient, you saw that patient is malnourished with temporal recession, loss of muscle mass, looks emaciated and bit cachexic. So you will expect some questions about malnutrition or nutritional assessment or nutritional status or how to optimize the nutrition. One. Number two, you saw there is a tracheostomy anxiety, so there will be few questions around the tracheostomy, indication, types, complications, and all those things. For this patient, you have a check feeding. At the same time, there is a TPN ongoing, so you may have questions on both. So definitely, when to start, what mode of feeding is better than the other, what do you look for in feeding, and how do you assess, and all the feeding related questions that can come. And the last and not the least, you have a chest tube which is bubbling, which the patient has probably a bronchopleural fistula, and questions regarding that, how you manage a bronchopleural fistula and all those things. So you just, when you see a patient with bunch of finding, try to figure out, okay, I'm going to be asked about these questions and what is the punchline in that. So there are 2-3 points in each of those abnormalities that will score you the mark, and the examiner will be looking at it. So we'll go across that gradually as we proceed from here. But that's how I would approach the case, and try to fit everything like a jigsaw puzzle into my case and present it. So and the leading question going into the exam is most important. So as in this case, it says examine the patient and enumerate his current issue. So never forget about that line. So what the examiner asks you as the leading question. He may ask you, examine the patient and let me know why he is in the ICU still, why he's not going home, or why he's not being discharged. Or just just summarize this case. So just make sure that you understand what is the opening question, because that is the money to start with. The examiner wants you to be listening to his question and to be to the point what the exact thing is being asked at the beginning. And I would advise not to start in a generalized manner, saying that every question you are going to summarize the case the whole. He came on this stage like that, and he has developed this on different dates and all those things. So because you don't have much time in the viva, so to the point, what the examiner has asked in this case, examine the patient, which you have done already, and enumerate his current issue. So let's go to the answer now, right? What are his current issues? So in this case, as you can see, generalized deconditioning. He's a malnourished individual, possibly due to the cancer, who has lost 5 kilos. He has an artificial airway as a long-term tracheostomy. That's because of his underlying pathology to overcome the airway obstruction. He is on oxygen and high flow dependent. There is a bronchopleural fistula with an ICD in situ. He has high risk of micro and macro aspiration, this patient, and he is currently on enteral feeding with a PEG tube in situ. So these are the major 4-5 things that you can talk about. Always put finding into perspective. Don't think that the things are as such in there. So if you lose, or if you fail to identify the PEG feeding tube, if you fail to identify the ICD, or if you fail to identify a tracheostomy in this case as an issue for the patient, then you will lose mark, right? And the initial question, make sure that you answer it correctly, or the best possible effort into the initial question. You take around 1 or 2 minutes at the end of the examination to gather your thoughts. So like if you have 10 minutes to examine the patient, try to complete it within 8 and 8.5 minutes, so that 1.5 minutes when you are washing your hand again, or trying to dress up again to go to the examiner, or just walking to the examiner, you gather your thoughts, how I'm going to talk or articulate your words in there within that 1 and 1.5 minutes. Okay, that's very, very important, because the first impression does last a lot. Okay. Now, so most of the cases, they start with a general question like, what is the current issue, or summarize your finding, or what is the cause of the current abnormality you think. So all these are generalized questions. So always those general questions, always try to break it up into points. Like in this case, what is the current issue? So going from head to toe, or whatever you think the appropriate format of describing the issues, start like that. So in this case, whichever is the most important thing you think, you can start like that. He has an ongoing respiratory infection. He has a ICD in place. Then he has generalized malnourishment. So in that way, you formalize your answer, whether it is a priority based or whether it is a organ based. Always have a structure to answer, not like that. So saying that, oh, he has a generalized weakness, then the third point comes as, oh, he has a bronchopleural fistula. Then the second point comes as, or he has a PEG feed in situ. So make a pattern of answer. Either you go from head to toe or by system, so that it is heard in a better way by the examiner. Now, the second question, as you see, there is a tracheostomy. Please enumerate the clinical indication of tracheostomy. As I said in the beginning, there are numerous devices in this patient, and your viva will definitely track towards one of them. If you have answered the first question relatively well, then the second question will straight away flow about a device or about a particular problem in this patient, right? So in this case, the tracheostomy, the indication of tracheostomy. Now, in a Viva exam, the most important thing is to make sure that you go by a definite pattern of answering. So don't start randomly saying that the indication of tracheostomy can be due to airway obstruction or prolonged ventilation or neurological injury or something like that. So yes, you are correct, but the examiner wants to see the pattern of answer from you. So there may be numerous pattern of answering that. So in this case, I have answered like a emergent indication, elective indication, or you can say neurological indication, other system indication, or any ways of classifying. So start with a broad and then gradually go into the each step of the classification. This is beneficial because sometimes you may not have much time to answer. And if you give a structure of classification like emergent and elective, few of the examiner may say, oh yeah, this chap knows about the answer, so I will give you the mark in the beginning. I'll step down and go to the next question. Sometimes it happens when you are struggling with time, when they want to ask you more questions to evaluate the depth of knowledge. So in that case, it is very helpful to have a structure to start with. So just start with like I will classify the indication as emergent or elective. The emergent indication can be upper airway obstruction such as angioedema, anaphylaxis, any neck hematoma or infection such as a submandibular space infection or retropharyngeal abscess or a mass such as a malignant or a benign tumor, foreign body that cannot be removed to bypass the obstruction. The second emergent indication is post-cricothyrotomy to formalize the airway. The third can be severe airway or facial trauma like a D4-3 fractures of the midface, where the securing a definitive airway or a orotracheal intubation is difficult or impossible to do. The other elective indications are anticipated to require prolonged mechanical ventilation, poor airway protection, such as patients with neuromuscular disorder associated with bulbar weakness or recurrent aspiration. The third can be severe supraglottic stenosis unresponsive to conventional therapies, and patients with severe vocal cord palsy or paralysis who are refractory to other therapies. So in that way, you just classify your answer, even if you don't tell 3 in each, but at least you have a pattern and that will score you mark. And you can see on the answer grid, they ask for 2 in each or 1 or 2 in each. So that will give you the marks. Suppose this one has 2 marks. So they will tick off the 2 and then step to the next. Okay, the emergency indications are done. Now tell me some elective cases like that. Okay. Now, third question here. What is your opinion versus early to late tracheostomy in ICU? So if you have a tracheostomized patient, these are the box standard questions, right? So what is your opinion, early versus late? So just take a deep breath and think about what the examiner is asking. They're asking about your opinion and backed up by probably some evidence. These are the 2 things they will be looking for. So for the answer, there is no major advantage of performing early tracheostomy if it is done less than or equal to 5 days of endotracheal intubation. There are data limited in specific population, and the recent RCT in severe stroke, early tracheostomy, which was done in less than 5 days versus more than 10 days, did not show any improvement in survival. We know the landmark trial of TrackMan trial, they did not show any advantage in early tracheostomy. So this is the gross or the overall point of view of early tracheostomy. If they want, they can dip in further, asking about where do you consider early tracheostomy, or they can divert into some other question, right? In this case, I thought I'll go deep into that indication. So the next question is, how will you decide which patient will need early tracheostomy? Again, have a format of answering, right? So in this case, I have enumerated around 10-12 causes, and the causes where you have a long list of causes, they expect you at least 4 or 5 things to be uttered, because it will have 2 or 3 marks and each cause will have half mark to 1 mark in there. So always go by broader differentials to that. And once they have ticked off the required number, as you can see, I have written 5 or 4, they have ticked off the required number of answers, they will switch to the next question, say, oh yeah, he knows about it, right? So in this case, what are the indication for early tracheostomy? is a cervical spine trauma, especially trauma resulting in transection of spinal cord at the level of C3 to 5 or higher than that. Then traumatic hypoxic brain injury, neuromuscular conditions such as severe progressive and slowly resolving bulbar amyotrophic lateral sclerosis, severe Guillain-Barré syndrome. Now, poor pre-hospital functional status, which can have the anticipation of prolonged ventilation, poor nutritional status, again, which is a determinant for prolonged ventilation in some cases, poor pulmonary function, where the patient cannot clear his secretion, advanced age, associated significant cognitive impairment. If the patient has a nosocomial pneumonia, which is taking time to improve, and you need to administer aerosolized treatment in this patient. If the patient has ongoing proven aspiration event to protect the airway for a longer or medium to longer term time period. If the patient has multiple failed extubation and reintubation requiring long-term ventilation support, in that case, early tracheostomy can be considered. And if the candidate is able to provide any other rational indication, they can consider that. Yeah. So in that case, always have a pattern of answering. You can see here, we talked about the neurological cases, which are the major indication for early tracheostomy, and then go for some general causes such as nutritional status or pulmonary or advanced age or cognitive decline of the patient. And the third one is respiratory causes. So these are the three major classification of the indication for early tracheostomy, right? Now, Tapas, am I going very fast or?
No, you are okay.
Okay. So I think you would keep your watch about the chat box if anyone has any question. So
yes,
we can
yes,
talk
yes.
about it.
I am tracking.
Or if the other faculties want to jump in and add on anything, please feel free to do that.
So I would request, sir, if you at this point of time anything to share to the candidates. Yeah.
Multitasking. Hi, Tapas.
Yes, sir.
Can I come in?
Yes, sir. Yes, sir. Yeah, welcome,
Hi,
sir.
Tapas.
Yes, sir.
Thanks, Tapas. I think fantastic initiative. Thanks for getting me in here. I think it's a great way of teaching our budding intensivists. Okay, so this is a very challenging and interesting case. So one is, of course, there is a situation of an advanced laryngeal malignancy with airway obstruction, and so there's a tracheostomy. There's of course a nutritional problem, and there is this very interesting bronchopleural fistula with an ICD, which is a little unusual in this setting, but for whatever reason seems to have happened. So I think in addition to what has been very nicely and thoroughly discussed so far, I would put in a couple of other things. One is, how do you manage a displaced tracheostomy? You know, you've done a percutaneous tracheostomy today in the evening, and at night it gets displaced. So how do you recognize a displaced or an obstructed tracheostomy, and how do you handle in the setting of a early, within 72 hours, because when a tracheostomy is done, you have a tract which is formed, but that takes about anywhere from 2, 3 to 5 days to be fully formed. So if the tube comes out, then there's a challenge sometimes in getting the tube back in. So management of a displaced or an obstructed tracheostomy. And secondly, I would be if I was examiner, I would always quiz people on the ICD. What is the principles of the ICD? How does it act as an underwater seal? What is the principle of a 1 bottle, 2 bottles, and 3 bottles? What is the arrangement of bottles? What is the role of suction when you have a continuous bubbling, whether it's a bronchial leak or whether it's a parenchymal leak, a leak from the lung parenchyma? So these are some of the additional issues that I think would have been interesting.
Yes.
And a good candidate, I would definitely ask about the ICD.
Yes. So that was, I was about to just utter, because your points are for the candidates who has already scored more than 60% or 70% marks. The principle behind all these ICD and the bottles, 2 bottle, 3 bottle, the suction pressure, then blockage of the tracheostomy in the overnight, and how you will be securing again the airway, the difficult airway. So these are the beauty of having senior examiners at the national level. Sir has almost 25 to 30 years of vast experience. Thank you, sir. Thank you.
So Tapas,
yes,
I'll just come in. A displaced track is a basic question.
Yes, sir.
The ICD principles is like you mentioned, a scoring question.
Right, sir. Right, sir. Very well taken, sir. Yeah. Thank you, sir. Dr. Abraham, sir.
Yeah. Okay. Like for me, what I've nearly seen is like what. Sorry, I didn't get the name of the presenter, Doctor.
Yeah, he's Dr. Sananta, sir. So
Dr.
he's in
Sananta.
Australia. Yeah.
Yeah.
Yes.
Yeah. Okay, Dr. San. Like what Dr. Sananta said, the first question on that we asked the candidate to say, can you summarize the patient's condition and highlight what are his present issues. So what we find is a lot of our candidates do not know how to do this, and they get carried away and they try to impress by telling all unwanted things. I think the only way the candidate can master this is by doing more presentations on the bedside before the examination. There is no quick way to it. And also, when you're on call, calling up your consultants and giving a brief update on how the patient is. Okay, you cannot at night give a full history. New patient has come, you have to give a gist. Okay. And that is learned only by actually doing it, and you cannot learn it theoretically. So that is extremely important because as he said, that's where the impression is created. If you're completely jumbled up and you're not going in a systematic way, the examiners get the feeling that, oh, this fellow is not organized. I do not know how he's going to take care of this patient. And from there, the next question comes, and you have to really work hard then to impress them. I think that's one. Second, a lot of examiners, like what Dr. Divatia just said, has got their favorites, like airway, for example. They see a tracheostomy, even before going into the detail, once the initial presentation is given and say, oh, what is that? And then how will you manage, how will you identify whether the tracheostomy is in place or things like that, that catch on that. Basically, what the examiner is looking at is, if I am going to hire this person as my associate, will he be able to take care of the patient when I am not there? So that's the first thing they look at. After that, only they will go into higher mark questions to make sure whether this fellow is going to be a star candidate, distinction candidate, whatever it is. So the first few questions are to assess, can he convey the message in an organized manner? Can he take care of my patient, of the patient in a safe manner? And if he tick these two boxes in the first few questions, he has already passed. Then it's just for distinction. Okay, that's all.
Yes, sir. The message is totally clear as well as loud. So yes, we have to be safe for the patient as well as for our attending. Yeah.
Correct.
So that's the message. Yeah. Yes. Yeah. Dr. Sanand, you can proceed. Thank you, sir. Yeah.
Thank you for the input, guys. So now going to the next question. What are the types of tracheostomy, as it can track into further questions on that? So the answer are very simple: surgical tracheostomy and percutaneous tracheostomy. Now, the next question can tail out into different ways. So they can ask you about the process of the procedure of tracheostomy, which I will go in later on, or any question related to tracheostomy as we are discussing, like a dislodged trachea, how you manage on day 1, day 2, or things around it. Okay. So the next question here is, what is the emergency approach to secure airway in a cannot intubate, cannot oxygenate situation? It can fall like that straight away. So you have to answer like, what is your practice? In my case, I will go for a scalpel blade technique or emergency cricothyroidectomy, procedure. So these are the two things that we can do for a cannot intubate and cannot oxygenate situation. Now, if they are talking about emergency approach, they can tell you how to be prepared for a difficult airway. That is another question, airway going into the airway viva. Or they can continue again with the percutaneous tracheostomy. In this case, I have decided to continue on the percutaneous tracheostomy. So name few technique for percutaneous tracheostomy. So this is an important procedure. You need to know in and out of this procedure, because This is bread and butter in ICU. So you need to, because we do that, we need to know about the procedure. It's just like putting a central line nowadays. So it is, you need to know in and out of the anatomy and how do you do it and what are the possible complications with the procedures that we do day in and day out in ICU. So name few technique for percutaneous tracheostomy. So in this case, Segalia or multiple dilator, or the layman language of blue rhino technique. Then Gibbs forceps technique, then balloon dilatation technique, then few other techniques such as the translaryngeal technique or the Parker twist technique. So you are not expected to tell all of this, but you need to tell at least two: the Segalia or multiple dilated blue rhino technique and the Gibbs forceps technique. So these are the two at least you need to utter, because they
Excuse
are
me,
the
Doctor, can
more.
I just butt in for a minute?
Yep.
Yeah, just quickly about the techniques. So as an examiner, if I look at it, if the candidate is doing one technique and knows that technique, I mean, that should be okay, because the rest of it looks like a theoretical question, like,
Yes.
theory when you write down. On the
Yeah.
bedside, have you done a percutaneous tracheostomy? Yes. What method have you what method do you do in your hospital? Have you done it personally or have you assisted? If you're done, okay, fine. May I ask them, just to make sure whether he has done it, how is it done? Now, quickly tell me the procedure.
Yep.
Thank you.
Agree. Yeah. So you need to know about the procedure, but at the outset you need to be very frank that yes, in my ICU we do it, or in my ICU we ask the ENT guys to do it. Any of those are correct, and nobody will question about your approach. But if you say yes, I know about it, or we do it, and cannot answer the question, then you will be probably in trouble. So you need to be very frank at the outset. In this case, because there are still few centers, I believe, they don't do percut trachea, and they may be asking other people to assist or do it. But there are few things, like if somebody asks you questions about central line placement or a central venous cannulation, and if you say I don't do it, then that is not acceptable. So it has to be weighted what they're asking about. But at least you need to know the name of the technique that you do, at least one of them, as Dr. Abraham said. Yeah. Now, again, going detail of the tracheostomy. So if there is a tracheostomy or a percutaneous tracheostomy question, they will ask you about the complications for sure. So enumerate the possible complication with percutaneous tracheostomy. Again, the classification of the answer is important. If you classify, saying that I will classify the complications as immediate, early, and late, or you can tell local complication, systemic, any sort of classification. There is nothing wrong or right in any classification, but just utter few words in. I will talk about the immediate complication first. That means the examiner knows that you are going to talk about the late complication or early complication next, and they will try to sweep across the question very quickly. They will just assess whether you know it or not. So always have a pattern of answer, not just like jumping, saying that, oh, infection as the first one, then the bleeding is the second one. Though all of them are correct, but they don't sound that succinct in your answer. So always have a classification to answer it. And the way of doing it is practice before the exam, right? You always hypothesize that, or create a situation that you are asked this question, how you are going to answer. So today you will stand in front of the mirror and say, okay, I'm being asked what are the complications of percutaneous tracheostomy, how I'm going to answer. So I'll say, I'll classify the complication as immediate, early, and late. The immediate complication being hemorrhage, subcutaneous emphysema, loss of airway leading to inadvertent extubation, decannulation, complication associated with depressurization, which includes de-recruitment leading to hypoxia, pulmonary edema or negative pressure pulmonary edema, cardiac arrhythmias, bradycardia, hemodynamic instability due to anesthetic drugs, and which can amount to cardiac arrest in certain situations. The patient may have bronchospasm because you are directly handling the airway, and there are chances of aspiration pneumonitis. Then other immediate complication can be due to the injury of the surrounding structures such as thyroid, vessels, nerve, esophagus, and post-tracheal injury, which can culminate in further complications. And other procedural complication, which includes loss or fracture of the guide wire, lateral stoma placement, and fracture of tracheal ring or cricoid, which can lead to later long-term complications such as tracheal stenosis. The other early complication that can happen is dislodgement of a previously well-placed tube. There may be chances of surgical site infection, tracheitis, mediastinitis, sternal lobe infection if there is an associated sternotomy. The patient can land up with swallowing difficulty in medium term. Then long-term complication, as I talked about, tracheal stenosis, tracheomalacia. The patient can have life-threatening situations such as tracheoinnominate artery fistula. There may be tracheoesophageal fistula due to pressure necrosis of the tissue. There may be osteomyelitis because the tracheostomy tube is very close to the sternoclavicular joint. The patient can have ongoing aspiration and complications such as pneumonia out of that. So you can classify the answer. You don't have to utter the whole list. 2 from each will do, and the examiner will judge how deeply you know. If you talk about the classification to start with, they should be okay to pass you the full mark in this case, right? The important things that you cannot miss is probably the bleeding, subcutaneous emphysema in the immediate stage, as Dr. Devatia was saying, loss of the tracheostomy or dislodgement of the tracheostomy, and also the tracheoinnominate fistula. These are the buzz answer to the complication, so you should not be missing on that. But again, that is not a major issue. You should be getting most of that if you have a classification at the beginning. Right. Now going into further, you mentioned about the malnourishment in the patient. In the beginning, you have talked about the patient looks malnourished. Then this viva then tails gradually to the nutritional aspect, which we may include further feeding, how do you feed, TPN, and all those things will come into play. So you need to anticipate, pre-anticipate what is happening or what is going to be asked. So if they start talking about malnourishment, then the next question will be how will you assess the nutritional status? This is probably how it runs, okay? I'm not saying 100% you are going to be asked about these questions, but these are the most important or probable question that you're going to have, right? So you mentioned about malnourishment. How will you assess the nutritional status in this patient? Again, this is a very, very important question in the exam. And nutrition is a big part in the exam, right? So assessment or nutritional assessment is a very important viva question. You need to have the answer ready beforehand. So you need to practice this before going to the exam. There is a very high possibility that you will get this answer or question. So have a classification in mind, have an answer made in your mind, practice it before stepping into the exam scenario. Okay, not on the exam day, before, like today, tomorrow. Just make sure how you are going to answer this question very succinct way within the limited time period, right? For me, I have decided to answer in the following way. So the nutritional assessment can be done with its clinical history, clinical examination, and associated investigation that we can do in this patient. The history includes the dietary habit preceding to the illness, whether so how ill he was before coming to the hospital, what is the time frame, his usual food habit, whether he is very selective in his food or whether the patient is a good eater. What's his social status, can afford food or not, that also determines the baseline nutritional status. If the patient has any associated habits such as alcoholism, substance abuse, whether he is well kept or not, and associated comorbidities, which includes diabetic nephropathy, CKD, hemodialysis dependent, chronic liver disease, and all those things that can put the patient into malnourished category. Now, these are the history of the patient. The second is some clinical examination finding, which includes the anthropometry, that is weight and height as per his age and height. The muscle store that he has or not. In this case, the patient has temporal loss of muscle, which is an early sign of malnourishment. Skin fold thickness, whether that is adequate or not. Other signs of malnutrition and vitamin and micronutrient deficiencies, such as vitamin deficiency leading to angular stomatitis, glossitis, gingivitis, having pitting edema, which is a sign of anemia, again nutritional anemia, and other skin changes that can be present on the outset. Then the investigation that can give some clue about the nutritional status of the patient, which includes the serum albumin or prealbumin, though they are very non-specific and may be misleading. The serum creatinine, if the patient has good muscle mass, they can have a acceptable creatinine level, but if they're malnourished, they can have a very, very low creatinine. Other electrolyte abnormalities associated with it, such as other dyselectrolytemia, which is an indirect indicator of ongoing malnourishment of the patient. And we can do vitamin levels to see how vitamin rich or poor they are. So these are the ways of assessing the baseline nutrition of the patient in the ICU. If you tell your answer saying that clinical history, clinical examination, and investigation, that ticks off most of the boxes, and then start going in detail a little bit of that, the examiner will probably stop you there, knowing that, oh yeah, he knows about how to approach it. So I'll step into the next question. Okay. So I again emphasize, always classify your answer, or always have a pattern about it. And this one will not come exactly in the exam. You have to practice it beforehand going into the exam. Make a habit of it. It will come in the exam automatically, right? Okay, going to the next question is, how will you optimize nutrition in this patient, thinking this patient has a current body weight of 60 kg? Now, take a breath and understand what the examiner is asking. Optimize the nutrition. If it is optimized, what are the things you are going to answer there, right? So make a pattern again. I will assess the nutritional status and requirement of the patient. In my general practice, I go by 25 kilocalorie per kilo per day, which is 60 times 25 is 1500 kilocalorie. I will feed the patient with 1.5 to 2 grams of protein daily, which accounts for around 90 gram of protein. That's his energy and protein requirement. But you can suggest any other method, up to you. But usually the 25 kilocalorie per kg per day is the best answer we go by. Then you can get some extra mark if you said that we can compensate for increased metabolic state of the patient, which includes the cancer, chemotherapy, inflammatory state, and may consider increasing the requirement by 25%. In my practice, whatever you do, just tell whether you do it or doesn't do it, nothing right or wrong. But if you have an answer of this sort, then you will definitely score more marks. So first of all, assess the nutritional status of the patient, say that this is the requirement. Assess the route of administration. So enteral versus parenteral. I would prefer to start enterally, that is a nasogastric, versus a peg or a judge feed, depending on the tolerance. In this patient, I have noticed that he has a peg in situ already, so that issue is already taken care of. Then you can say that I can consider supplemental TPN if target is not achieved within 3 days or 4 days and patient has ongoing intolerance. So I will decide depending on the tolerance of the patient and whether we are achieving the target or not to consider supplemental TPN. But in my regular practice, I will give 48 to 72 hours to look for tolerance. And I'll optimize the tolerability with some gastrokinetic agent if possible, which includes, in my practice, I use metoclopropamide or anything else. You can talk about it, right? Now, again, the division of the question or division of the answer needs to be there. So assess the nutritional status. If you tell the examiner, I will assess the nutritional status by whatever means, then I will assess for the route. It is already been fixed. It has the patient has a peg in situ, so that has been taken care of. And I'll assess the tolerability. If not, then I'll optimize the tolerability. Right? So that's the complete frame of answer, which will give you the maximum mark. Okay. Now, if they utter about parenteral nutrition, then the questions about parenteral nutrition are 100%. They will come next. Okay. What are the questions that can be asked in parenteral nutrition? So when will you consider total parenteral nutrition or a TPN, right? So these are the box standard question in the exam. I would recommend to prepare the answer before going into exam scenario. Okay. If nutrition is being asked, they will ask about total parenteral nutrition. They will ask about the indication of total parenteral nutrition. So the answer from my side, how I will tell, is general. So in that case, feeding into the GI tract is contraindicated because of some surgical cases where the continuity of bowel is not there or it is not assured of, Enteral feeding fails to meet nutritional requirements as a supplement to the enteral feeding, and enteral access is unobtainable because you cannot place a nasogastric, or you have time for placing a peg in place in the patient, that then you can start the TPN to start with, right? And pre-operative parenteral nutrition, in some cases you have to give. It is indicated if the operation is to be delayed for more than 3 to 5 days and the enteral access is not possible. In severe malnutrition, then preoperative parenteral nutrition is recommended. So if the patient has malnutrition to start with, to optimize his nutrition to go into the surgery in a more safe manner, you can start preoperative parenteral nutrition. Post-operative parenteral nutrition indicated in mild to moderate malnutrition, where oral or enteral feeding is not possible within 7 days. You can tell 7 or 5 days, up to you, up to your practice. It should be considered in severe malnutrition after 5 days. As I said, 5 to 7 days. If you are not able to feed the patient, then you can consider parenteral
I
nutrition.
request everybody to please mute their mic. Yeah.
So again, pattern of answer, very important, how you answer. So indication of TPN, you can tell general indication, pre-operative and post-operative. That means you know around the facts, know the facts around the TPN, okay? Now, what are the possible complications of TPN? These are, again, the following questions are very, very box standard. If you are asked about TPN, then there will be complication. Now, the answer to the complication is, first, catheter-related sepsis, catheter occlusion. There may be disorders of glucose control. The patient may land up with hyperglycemia, hypercholesterolemia, the high risk of refeeding if the patient has baseline diagnosed or undiagnosed malnutrition. The patient can have abnormalities in liver function tests, and other problems that can happen is the patient can lose some bone mass, which is probably not known. The pathophysiology behind it is not very certain, but they can lose bone mass, and there may be decreased GFR, again because of the unknown etiology of that. But probably the bone mass that they lose is because of immobilization, so that the patient is that sick requiring the TPN. That's the cause of it, but they are all associated complications that can happen, right? Now going to the next question. Suppose I'm just rushing through a bit because we may not be able to complete everything in 2 hours. So I'll be a bit fast on my approach again. So 2 days after commencement of TPN, the following are the clinical and laboratory values of the patient. What is the most probable cause? Again, refeeding syndrome after TPN, 100%. You'll get this question, right? Always get ready with your answer with this. So always pre-anticipate or anticipate this question that is going to be asked after a TPN question, right? In this case, the patient has a heart rate of 134, tachycardic, borderline blood pressure, 78/50, or hypertensive. He feels very fatigued and tired. Overnight, he required to be put back on the pressure support ventilation as he was getting tired. So basically, there is a situation where the patient is tachycardic, hypotensive, and getting more and more tired, requiring higher requirement of ventilator support. When you looked at the laboratory finding, so hemoglobin, platelets, white cells are almost normal. He has a high urea. The creatinine is normal. He has a potassium of 1.8, which doesn't sound good. And the bicarb is 14. The calcium is low, even with adjusted to albumin. And the albumin is expectedly low. There is low magnesium, low phosphate, and he is hyperglycemic. So basically, this patient has hypokalemia, hypomagnesemia, hypophosphatemia with a low albumin and hyperglycemia. So everything else fits into a refeeding syndrome. So they'll be asking, what is the diagnosis here? Yep, refeeding syndrome, unless proven otherwise. Then they may go in detail a little bit about refeeding syndrome. What are the complications of refeeding syndrome that you need to know? Again, the classification is the key. Go by system. In cardiovascular, the patient may have heart failure due to overload. The patient will have hypotension, cardiac arrhythmias because of dyselectrolytemia, associated dyselectrolytemia. Gastrointestinal, there may be LFT derangement. The patient may land up with diarrhea because of, again, diarrhea is a cause of dyselectrolytemia, or as an effect. The patient may have ongoing arrhythmia again. They can land up with acute tubular necrosis because of fluid loss. The respiratory, as this patient has respiratory muscle weakness because of hypokalemia, hypophosphatemia, and that can lead to prolonged ventilator weaning and associated infection with that. Musculoskeletal, again, muscle weakness. The patient can have tetany because of low calcium level. Rhabdomyolysis because of hypophosphatemia. The patient can have rhabdomyolysis leading to renal failure, even with refeeding syndrome. The patient can have seizure, coma, and associated delirium because of dyselectrolytemia again, and your immunological function goes down, where you have more chances of having infection. So these are the complications that can be associated with ongoing refeeding syndrome. Now, the patient had a chest tube with a bronchopleural fistula, which may not fit to the pathology or pathogenesis. So why he should have a bronchopleural fistula? He can have a bronchopleural fistula if he has a COPD, with the long-term ventilation. They can have barotrauma that can lead to bronchopleural fistula, and all those causes can happen. So they can ask you why this patient has bronchopleural fistula, then you need to have answers regarding that. So it can be multifactorial, then you can classify your answer. But in this case, we're not going to the cause, we are going to the management of a bronchopleural fistula. Now, the patient has a bronchopleural fistula. How will you manage the fistula? Again, if you are talking about management, so always the management had two parts. One is a definitive treatment, and the other one is associated or general treatment, right? So somebody with a bronchopleural fistula, there will be a definitive treatment part, and there will be a management of the bronchopleural fistula as such. So ventilator treatment includes probably avoid positive pressure ventilation in this patient as much as you can, put them into pressure support or liberate them from the ventilator as quickly as possible. That's the most important treatment modality. Now, drainage of the air. So if there is ongoing leak and if there is ongoing subcutaneous emphysema, the patient may need a wide bore ICD, need an additional ICD, and you may need to add on suction to the patient. As Dr. Devatia was asking, what is the indication of suction? This can be the suction is because if there is inadequate drainage of the air causing progressive subcutaneous emphysema. Now, definitive treatment of bronchopleural fistula is usually an expectant approach. Usually they heal up unless it is malignancy associated or infection associated. They take time. Otherwise, they usually heal up in a week or so. So expectant approach, or if it is not healing, then there are various ways of fixing it, which includes the bronchoscopic guided glue or plug versus thoracoscopic surgery versus open surgery. So there are various ways of fixing it definitively. So if they are asking about management, talk about ventilatory management, drainage of air, and definitive treatment, along with improving the functional status of the patient, which includes improving the nutrition, which will help in wound healing and better healing of the lung damage that has happened. Now, what is the recommended ventilatory management of bronchopleural fistula? So this is again an important part. If you have a bronchopleural fistula patient, they will ask you about the ventilatory management. So if there is a ventilatory management question, you always talk about what mode, then what, I mean, I'm not talking about this specific, but in general, what mode, what is the setting in the ventilator, and how you monitor that, right? Always these are the three things you look for or talk about. So in this case, mode, allow the patient to breathe spontaneously as much as it can, preferably extubated. If the patient stays in a controlled mode ventilation, requires controlled mode ventilation, in that case, we'll look for high inspiratory flow and decreased inspiratory time so that the leak is minimized. There will be some leak, but the time given for the leak will be less, so there will be less air leak in this patient. So high inspiratory flow and decreased inspiratory time. So that's the pattern you go for a bronchopleural fistula ventilation. Oh, I think I have completed the case, Tapas.
So thank you for the elaborative discussion flow, as well as the questions, as well as the suggested answer. Now the floor is open to our mentors. Dr. Devatia sir, please. Dr. Abraham sir.
Yeah, I'm here.
See, this the whole case was the way you went through was excellent. You covered a large part of the questioning, which ideally in a exam setting we never will be able to cover, because a lot of time the discussion gets carried away in one angle, then we come back to guide the candidate back into the right path, and we will not be able to cover the whole thing. That's one thing that you need to know. The other thing is, as I said, it's before the exams. A lot of things I see with even my candidate is a lot of them have finished their rotation. They are waiting for their theory exams to come, theory results to come, and then go for the practical. They've gone home. Please don't go home and sit reading your theory, because what you have learned for 3 years, is enough. You're not going to learn more. And in fact, you will know more than what the examiners know, because you have read the recent developments and latest things. We examiners would not have read so much when we come for as an examiner. So you need to go to the bedside and present cases. Unless you do bedside presentation daily, you will not be able to present in the way that was presented just now. Okay. In a systematic way. Every question being able to organize the answer in such a way that the examiner gets to feel that you know the answer. You are an organized person. Okay, so unless you practice it, there is no way you'll be able to do it. So I think what you have done now for telling them what to do, it's fantastic, but they have to practice. There is no way that they can listen to this and think, oh, I'm going to do it, unless you practice. You may have another 7 or 10 days before your practical exam comes. Go back into your ICU, catch hold of your examiner or your consultant and say, I want to present. And just keep presenting. Unless you present, it will never falls into an organized pattern. And I will just stress on that. You have to do bedside presentation. I have nothing more to add.
Yeah, totally agree. That is the clue, and that is the best thing what we can do in the remaining days. Yeah. Divatia sir, anything, sir, from your side?
Yeah, no, Tapas. Yeah, Tapas. So, this was like I mentioned earlier, this was a very good case because it had 3 or 4 aspects. And as Babu pointed out, the key is identify what are the problems, what are the main problems which need immediate attention. Now, in this case, there are not that many that need immediate attention. And what are the other problems which require attention in the course of the stay in the ICU. Now, the nutrition part is extremely important. This patient is severely malnourished. You see, there's a 35 kilo weight loss. And we can debate on whether you should have pure enteral nutrition or a combined enteral plus parenteral nutrition. And I think that was brought about in the discussion that happened. Now, the refeeding syndrome was also nicely covered. So I think when you, in a case like this, where there's a nutritional problem, where there's a tracheostomy, where there's a PEG, and where there's a laryngeal cancer, where there's a bronchial fistula, there's aspiration pneumonia. When you present the case, we traditionally do in the ICU a top to toe exam, but you need to integrate, and that's where Babu also mentioned, I would agree with him, that you should keep presenting such complex cases where there are multiple devices, multiple problems, multiple interventions going on, so that you are able to present in a logical fashion to your examiners. That you somehow have to get the malnutrition in. You have to say that the patient is receiving feeds via PEG. You have to say the patient is receiving feeds via TPN. You also have to say he's got a tracheostomy. You've got to say he's got a intercostal drain. Care of the tracheostomy, I think, is extremely important. And one of the very important aspects in this, which would be covered, would be the care of how do you prevent VAP in a patient who's got a tracheostomy and who's got a long-term sort of tracheostomy, plus minus mechanical ventilation, like happened in this patient, right? So someone would Then also the management of aspiration pneumonia. Would you give prophylactic antibiotics? Would you only give antibiotics if there was a fever or if there was evidence of pneumonia? All these things will at some stage be discussed. Of course, it would depend on how you're answering and how you're presenting and that sort of thing. But these are things someone needs to be prepared for in a case like this.
Thank you, sir, for that input. I think the candidates need to at least note down what are the possible questions that the examiner is going to ask. And it doesn't have to be only in this case. Any case can percolate to any of those scenarios. So as Dr. Abraham was saying, practice is the main thing. In my setting, before the exam, you have to do 80 cases to be confident in the exam to answer the examiner. So that's how it is. More or less, depending on how intelligent someone is, but there is no replacement to practice cases. All right, Tapas, I will sign off now and go for the second case by Shantanu. I think he has some issue with his internet connection in the hotel, but I think we should be good. Let's start with Shantanu then.
Good evening, everyone.
You are breaking up, Shantanu. Now I can see.
Anand, I think
Am I
he
audible?
will be able to do it because he has some network issue. Can you run it?
Let's see. I think he's okay. He can stop his video and share the screen. If it is not, then I'll go ahead. Are you okay with that, Shantanu, or you want me to continue?
Arun Sanant, we can start with the
If
table
I'm audible,
in the meantime because it's
I'm
already
ready to
past
continue.
18:10. So just to keep a track of the time, I would start with some the other practical things right now, and in the end, maybe we'll end up with the second case.
All right.
depending on the
Go
time.
ahead, Tapas, then. Yeah, go ahead.
Okay.
Share the screen. Yeah, trying to share. Is it visible?
Yeah, we can see your screen, Shantanu. Yes. Yes. I can see your screen. Shantanu, you may start. All right.
Is visible?
It is visible, but you are breaking off with your voice. Okay, Tapas, yeah, I think he will not be able to.
I will be doing that. Okay. Can you please stop sharing? I will be starting with the two important table viva, that is the critical appraisal as well as the communication first. Yeah.
Okay, I have stopped sharing, so you can share your screen.
No, it's
Shantanu needs to stop share.
yeah.
Yep.
Just give me some time. Okay. Am I visible right now?
Yes, yes.
Okay. So friends, after the first long case, because it's almost right now 8:15 and discussing in detail, definitely we need to be a little bit faster to complete the whole exam, all the long cases, short cases, as well as the other table vivas. So I thought I would be starting with the two important stations, that is communication, and second one is critical appraisal. And believe me, they are the major stations in any critical care practical exit exam. And for that, you need to be conceptually clear. And as advised by all the examiners, we need to follow some systematic approach. They are very high mark fetching if you do it well on that day. And the clue already advised and already reiterated by Dr. Abraham, that if you have done it well and multiple times in your training period, definitely you can answer it pretty well. Not a single day, like one day before you start practicing these things and you think that you will click on the day of examination. It's not going to happen, because these are like, no, you have to spontaneously follow with the examiner's questions. Now you need to brush up the landmark trials in each major critical care domain. That's the clue. So with that background, the communication as per the recent DNB super specialty as well as DM, it would be having 10 marks and you have maximum 10 minutes for that station. So I would be having two the case scenarios that normally happen in our day-to-day clinical practice, and how the questions and what should be the approach. So I will be making everything for you to learn also, as well as having one or two cases. So scenario one in front of you, it's a like day-to-day practice, and we have also like witnessed this type of situation. A 33-year-old lady underwent uneventful normal delivery with healthy male baby. Now she had no comorbidities. In the immediate puerperium, she developed sudden severe breathing difficulty before being shifted out of labor room suite and rapidly became unresponsive. The staff nurse called you and you recognized cardiac arrest has happened. You started CPR and called for help. Once your team arrived, her CPR was continued without any ROSC being achieved so far, despite more than 5 cycles of CPR already being over. You went out of that labor room suite to communicate with the relatives and found them in absolute denial and shock. This is the scenario, and you would get this type of clinical case scenarios in your exam. So now, the questions in front of you, straightforward. What should be your initial approach of communication to her husband, Mr. X? The second question, Mr. X, who is the husband, is right now, you are the Dr. YZE, and the husband is right now asking you, my wife was absolutely fine in the antenatal period before shifting to the OT, and post delivery also I got the information that she is doing well. Now you are telling me she is no more. How it is possible? This is the question number 2. Question number 3, again he's asking and he's doubting your the whole system. I'm suspecting some medical gross negligence might have happened with the wrong drug administration, and that has caused this to my wife. I cannot still believe she is no more. This is the question number 3. And question number 4, Mr. X is asking again, how is my baby? Is she fine or not? That's a girl child. So she's again having the query that what is about my baby. And question number 5, Mr. Y, who is the friend of Mr. X, is the maybe the family friend. His friend is threatening to call the police, suspecting some malpractice. What you should say and do. So these are the questions, and very rational questions that happens in some or other situations in our ICUs, more in current days. So to start with, what is bad news? Because it's a bad news. So any information that drastically alters the life world of the patient is termed bad news, and that adversely and seriously affects an individual's view of his or her future. Believe me, and everybody will agree with me also, conveying bad news is a skilled communication, and that the examiner wants to know from you that how you have done in your 3 years of training or 2 years of your fellowship or 1 year of fellowship. So why we should break the bad news? There are certain criteria why we should do for the ethical reason, autonomy, beneficence, non-maleficence. The examiner may ask you about these things. They may go into deeper of each question. Professional, because we need to communicate well, advocate, duty to care, human rights. The family relatives, they have the right to know and right to decide about the treatment. And also the legal part, that is the negligence, end of life care decision, as well as advance directive. So these are the reasons why we should break the bad news. What are the goals of bad news interview? That can be asked in the examination by the examiner. One is gathering information from the patient, then to support, to provide intelligible information in accordance with the patient's need and desire. Third point is to support the patient by reducing the emotional impact and also the isolation experienced by the recipient of bad news. And fourth one, to develop a strategy in the form of a treatment plan with the input and cooperation of the patient. So these are the goals of bad news interview. That may be a question, and they will straightforward go for the spikes protocol. That is a 6-step strategy for breaking bad news. Initially started with oncology, but definitely now more applicable to the critical care. I'm just going into the slide one. You have to read it in detail and practice it in your clinical counseling in your remaining days before your practical exam. SPIKES. S for set up the interview, P for perception, I for invitation, K for knowledge, E for emotions, and S for strategize and summarize. So this is the protocol. It need to be in your tip of the tongue, because that's the thing what we are practicing in our training period. The questions what were asked: what should be your initial approach of communication to Mr. X, who is the husband? You introduce yourself with your position in the hospital, and you start with that. Maybe I am extremely sorry to tell you that. So maybe your words, maybe your sentence would be having really empathy and consolation. Now, it should not be very blunt, very direct, and also it has to be in accordance with the person's perception as well as the emotions. Second question, I will be straightforward go, because we have running less time. The second question that the husband is saying right now, that my wife was absolutely fine in the antenatal period. So what happened that you are saying that she's no more? So your answer should be also involving that I totally understand. It is unfortunate and unexpected, but you have to quote from the literature that sudden cardiac arrest can happen due to obstetric as well as non-obstetric causes, which are well documented and proven in literature. And the causes could be pulmonary embolism, amniotic fluid embolism, peripartum cardiomyopathy resulting in congestive heart failure, and basal gyrus reflex because of the spinal anesthesia leading to the loss of the sympathetic tone. So this could be, I'm not saying this is not right, this is wrong, something like that, but yes, your answer should involve this type of sentences and the wordings. That is the whole idea of conducting this type of mock test. Now, question number 3, that the husband is suspecting that there is some medical gross negligence has happened, and that could be due to the wrong drug administration. And he cannot right now not accepting, or right now not believing that something has happened. So you can start with try to console, relax the patient's relative. It's not patient's relative or husband. Be empathetic and explain in simple non-technical words for easy understanding. No jargons, please. No amniotic fluid embolism, pulmonary embolism. You have to explain in the language in which the husband is actually able to understand. So there are certain clues. Conversation and information processing can be improved by start at the level of comprehension and vocabulary of the patient. Try to use non-technical words. Do not use the metastasis spread, sample of tissue, something like that. Avoid excessive bluntness. For example, you have very bad cancer, and unless you get treatment immediately, you are going to die. This type of bluntness is not advised for trainee or intensivist who are dealing with this type of bad news. Now, step 5 of the spike is actually here pertinent, that you have to respond to the patient's emotion, because the husband is not accepting and is blaming. So this is one of the most difficult challenges of breaking bad news. So it can vary from silence to disbelief, crying, denial, like also can injure yourself also by the family relative. So there are certain clues. I'm not going into detail. If patient cries, there are certain like suggestions what you should do. If the patient is angry or the patient's relative is angry here. If patient refuses the current situation, he refuses the diagnosis, then you have to do with certain protocol. Now, the last, the fourth question, how is my baby? Is he fine or not? Explain about well-beingness of the baby. If possible, take him to show the baby. And question number 5, the friend is right now threatening to call the police. Now, don't be combative or get angry or use aggressive words at that time. Involve the hospital administration at the earliest and security. You can call police through the hospital administration to update from your side about the whole situation, what has happened. And also you should involve the legal team, and also always it is advisable like to have a team approach and involve leaders as well as other multidisciplinary team members.
My aim was always to be better than what I was debuting.
So
this place helped me do that.
Can I request you to please mute?
I know, sir. I had always come to your room with sad news.
Okay. So the second scenario, I will be finishing this. A 55-year-old male needed a central venous line placement for parenteral nutrition. Now he recently underwent GI surgery and perioperative period went absolutely uneventful. Now he went to the postoperative ward.
So when are you going to come with good news?
Can somebody please, who is ever having right now, having the
Jiggy.
on mic?
Jiggy, I think your mic is switched on.
Yeah. Okay. So he recently underwent GI surgery and operative period went absolutely uneventful. Now he went to the post-operative ward and placed a right subclavian line without ultrasound guidance, as no ultrasound machine was available in the ward at that time. After 2 hours, you got a call from the ward that the same patient was having gross respiratory distress and tachycardia. Subsequently, immediate evaluation revealed presence of tension pneumothorax, for which appropriate interventions were initiated. So this is again a common scenario, and that can be a question scenario in your real practical exam. So the questions in front of you by the examiner: how would you brief the agitated son and obtain the consent to put chest drain? Second question is, son is asking whether it was preventable. How you should guard the lack of ultrasound in your ward. Third one, son is calling down and asking about the future implications, what to say. So these are the questions and how you do communicate in the exam. So the question number 1, I would be a little bit straightforward, not with the theory part. You have to start with, again, introduce yourself, listen, be empathetic, describe the whole events in true. Don't hide the things or try to make a story and present to the son. And your plan is to stabilize the situation as soon as possible, because you need to take explain, need to take consent, and again do the next procedure, that is the definitive procedure for managing that situation, that is ICD placement. So it has to be quick, and also to explain the family relative with empathy. The second question, the son is asking whether it was preventable. So, and also why you have not used ultrasound, though ultrasound is actually advised right now in putting any central line. So you have to explain about the possibility of such complication in this procedure with usual incidence rate, and assure that we are on time in detecting the complication, and we are right now moving ahead with the ongoing intervention. And you have to guard against also the lack of ultrasound availability issue. Yeah. If they insist why ultrasound was not used, apologize with exact situation that hindered ultrasound use. Try to stabilize with utmost care after ICD placement, and again briefly also you brief again, procedure was over and vitals when you have started, and then try not to hide any facts. So that is the clue number 2. Third is the future implication. You have to explain the short and long-term complication of the chest strain, and it has to be all evidence-based. So these are the things related to communication. Now coming to critical appraisal. We have shared with all of you about that TTM protocol that is published in November 2021. And this is the article, hypothermia versus normothermia.
Tapas?
Yes, sir.
Sorry, can I just comment about that communication bit?
Yeah, yes, sir. Please. Yes, sir. Sorry.
Yeah. So I think all your points that you raised are absolutely correct and absolutely valid, and there is no question that this is exactly what you should be doing. Now, in a couple of instances, now your patients in all these cases are not competent, mentally compos mentis, but there are instances where patients have been mentally competent, okay? And when they are asked to deliver bad news or have options out of treatment, you know, many candidates have said that they will talk to the family and they will talk to the wife or the brother or the son or something. I think it is important to understand that if the patient is compos mentis, then you need to first talk to the patient. And many students have sort of not recognized this fact and go straight to the family, which is a part of the way we practice. But if you just look at the things, if the patient is competent, then you first need to talk to the patient. You may ascertain the views of family, but ultimately it is the patient's views that, if you take the principle of autonomy, that are paramount. So that is the one comment that I would like to make. And the case of the subclavian pneumothorax is something that resonates with me very personally, because when I was in Australia, I was a resident. I was the only brown-skinned person in that unit, and I had put a subclavian and created a pneumothorax, and I had to sit and explain to the father and the son of the patient that what has happened and what was happening. And without listening to you, I did exactly the things that you have suggested, and I think it worked very well. But I think that's something you need to keep in mind.
Thank you, sir.
And not hiding, not hiding, trying to fudge, right? Not writing notes. I think these are some of the worst things you can do in this sort of situation. So be transparent, be honest, and be upfront about all these sort of things.
Right. Yes. Thank you, sir. So, Abraham, sir.
No, I don't have anything to add. You can continue.
Yeah. So with the critical appraisal, we have supplemented with this article that was published recently in NEJM June 17. So the questions normally come for the critical appraisal. Does it have a valid question? Can you comprehend the focused problem here? Do you think the study has practical utility? So these are the first few questions that can come from the critical appraisal table. So for the article, again, due to paucity of time, I would not go into detail of that, but this is a format with which you can start your answers. The clinical question, what was the clinical question that has been asked in this article? Then what is the background of for doing this type of studies? What are the previous trials that have been conducted on the hypothermia protocol and targeted temperature management? The HACA trial, the TTM trial in 2013, the European Resuscitation Council guideline in March 2021. So these are the background what actually is right now propelling for this type of study. Then the question for the next set of like your viva would be, what is the type of study? Was it an ethical study? Describe the study design. That came in my mind, and you can answer like this. This is an international multi-center parallel group trial, randomized superiority trial. You will get all this information from that article itself. That would be supplemented to you, that would be provided to you in the exam, but you need to have eagle's eye to take the important points, because it would be only 5 minutes given to you to scan the whole article and then present to the examiner for the questions. So the blinding method, they can ask you what is the blinding method they have adopted in the study, what is the score they have used. It is the MRS score. So they may ask you what is MRS score. Now the next set of questions, how was sample size determined? They can ask you a straightforward question related to statistical analysis. What is the method of case and control selection in this study? What were the interventions they have considered? So again, the inclusion criteria, exclusion criteria I have just taken out from the study, but yes, you need to revised before entering into the examiner's room, so that you will be straightforward going into the question and answer. What are the interventions they have done? Again, it is clearly mentioned in the study. Whatever the control group, whatever the intervention group, whatever the difference that you have to go through, what was the management common to both groups they have done. So these are the things normally for any study, it is the like the basic protocol. So you have to scan this type of trials almost 15 to 20, so that in the examination it would be like a very pretty easy thing for you to answer these questions. Now the power calculation in this study, they may ask you straightforward. So I have taken that a total of 1862 participants gave a power of 90% with alpha of 0.05 and number needed to treat is 13.3. They ask you the basic like the concept of what is the alpha error, what is the beta error, what is the NNT, what is absolute risk reduction. So all these things you have to be clear for any study. So these are the basic statistical analysis that you need to be thorough. Was true randomization done? Were the study control groups comparable? Was the outcome defined well? That is normal questions for any trial when we do a critical appraisal. So it's also expected in your examination. So this is that for this study, primary outcome, secondary outcome, what are the serious adverse events that has happened and that were compared between the hypothermia as well as the normothermia group. Were there any sources of bias? What about the blinding? What are the confounding factors in this study? So these are again next set of questions. What were the statistical methods they used? So as I have already explained, so had correlation been distinguished from regression? So correlation coefficient been calculated or interpreted correctly? So these are a set of questions that can come. What about the odds ratio, the limitation of the study? What are the conflict of interest in this study? So these are the things you need to be thorough for this type of mock exam. Definitely it would be taking a lot of time. I am not going into detail, but yes, the format, the answer should be like this, structured, and that would give the examiner a impression that yes, you have done multiple times critical appraisal in your training period. And how you conclude your the study of this the article. So like in this study, I would conclude like in patients suffering from out of hospital cardiac arrest, induced hypothermia did not lead to lower mortality. Functional outcome and health related quality of life did not improve from hypothermia. These are the conclusion from this study, but how they may ask you your personal opinion. So that also you can tell in your I agree with the author's conclusion that cooling did not improve the outcome. Target temperature management is a very resource heavy and expensive intervention that comes with many adverse events. The present trial, in addition to evidence from the prior TTM trial, is the highest level of evidence we have on this topic till date, because this is the most recent one. Despite a different patient population, cooling has continued to show more harm than benefit. So maybe the role of targeted temperature management in post-cardiac arrest care is starting to shift more towards a greater vigilance on avoiding fever rather than keeping patient at specific temperature. Additionally, more effort and focus should be directed at bystander CPR, early defibrillation, and well-designed post-cardiac arrest care bundles in the ICU, rather than this type of resource-heavy and expensive procedure or intervention. Yeah, so this is from my side about these two important stations that is mostly neglected in our training period. We never go ahead with this type of communication as well as critical appraisal rather than only clinical stuff. So I thought of starting with the first. Any input from Devatia sir as well as Dr. Babu?
Yeah, Tapas, so this was a very good trial, the TTM2 study. And I think, it will be worth mentioning if any of the candidates mention that this is a very fortunate study which has come, because like you mentioned, it is not a resource heavy intervention. All you have to do is prevent fever. Although if you read the paper, number of patients in the non-hypothermia arm, in the non-hypothermia arm also required active cooling. But the bottom line is all you need to do is avoid fever and keep the temperature normal. And that in a resource limited setting, whether it's in your ICU or whether it's in India as a country, or so I'm sure many ICUs can invest in equipment and monitoring and nursing to get the temperature about 33, 34 degrees. But it's basically not required, and that I think is a very important message for resource limited settings like ours. So I think that's a very good thing.
Yes.
And another good thing about this study, this message was there in earlier trials as well. This was the largest randomized controlled trial till date, which has overcome the problems of power. So maybe if you're doing well and you're answering well, someone asks you, what do you mean by power? And what do you mean by sample size? And that sort of thing. So some technical questions on trial design and statistics may come up. So that's something
Yes.
a good candidate might have to be prepared for. But otherwise, I think it's a very simple study to interpret and
Yes, sir. Yes, sir. Thank you, sir. Dr. Abram.
Uh, Basically, I think what the candidate needs to know that is that when we give a article to them to look at, what we are trying to assess is, are they well read enough to know why was this investigation, or why was this research done at all? What was the burning question that they are trying to answer? So they should know the history around that, like what you showed, Tapas, in your slide. What were the studies which are done before, and what was the question, and that needed to be answered, and did that question get answered or not? So first of all, if they do not know anything about the subject, and then they are just reading the article without knowing what was happened before that, they may not get the full information. That's one. Second, what we look at is, are they able to look at the article and critique it? Even if they do not know the actual statistics properly, are they able to have a quick look at it, look at and say, have they, is the study a good study? Is it a study that I can use it in my hospital? Do the population reflect the population in my hospital? Does the intervention reflect an intervention which I will do in my hospital? And if that is so, was the study randomized properly? Did the two arms look the same to give you a good result? So these are the common things that quickly, as you said, they might get only 5 or 10 minutes to look at the whole thing. So when they look at it, if the candidate is able to scan through the thing to say that, okay, the study looks okay, they randomized it well, the two groups look okay, the intervention is something that I would do in my hospital, and it's something that is doable. And then they come to the conclusion, looking at the study, that there's something that I can do, I will not do. That sort of approach is what we are looking at. If a student does that and is able to discuss that, it's only after that when we go into the statistics and other things like, what is randomization? How do you think the randomization was done? Is there any flaw in the randomization? Was there a bias? Things like that. So the initial thing is, are they able to make use of the study, have a quick look at it and say, is this study something that is going to influence my practice? Answer is yes or no, and then go towards it. I think they should have that sort of approach with any study. Yes, if they do that well, then we'll go deeper into other parts of the study methodology and statistics.
Right.
So that's how I approach a paper.
Very valid point, sir. Very valid point. Yeah. So with that background, Dr. Sanant, I think as we are running out of time, can we just conclude with maybe 10-15 minutes our other table viva, or we would be
I think Tapas Shantanu is online. He has just texted. So I will go with the other case, which we can do it quickly.
Okay.
And keep the table viva for the next time, because it will take time.
Yes, that would be okay. Yeah. We'll be finishing in 20 minutes. Yeah.
Shantanu, are you still on there? Shantanu.
He has some major network issue. Yeah.
All right, that's fine. I can go through the second case otherwise.
Yeah,
But-
I think you should go ahead. He is having real problems. So let's.
all right, no problem. So let me share the screen. So I'll try to finish it in probably max 20 minutes. Yes, so let me, sorry. So the similar pattern, I will just run the 2-minute video to show you the case, and then, sorry, I'm not a great person for the Zoom. Yeah, there you go. All right, that's the second case.
Requesting all the examinees to please focus. Yeah.
All right, that's the case that has. So going a little bit detail on the, as I said, initially you will be given a clinical vignette to start with, and then you start examining the patient. So in this case, you have a, Tapas, I am audible, I believe.
Yes, yes, you are audible. Yeah.
So you have a 51-year male presented with history of abdominal pain, vomiting for 2 days. He denied of any fever and loose motion. He reported that he had similar pain, which was more at the area just under the right rib cage, and was going to his back 7 days earlier. It came acutely, which he relates to a heavy meal that he had in a marriage reception. This pain stayed overnight, making him sit up upright and leaning forward in the bed of the most of the night. It got better in the morning, and he was almost pain-free after 1 day. He did have few episodes of vomiting at that time, which he attributed to a probable gastroenteritis. On further questioning, he said that he had been having increasing dark coloration of the urine for last few days. He said he drinks around 3 to 4 standard drinks at night and might be more in weekend when he hangs around with his friends. He gave history of being a type 2 diabetic and had high cholesterol, for which he currently takes the following medication, which is metformin, exenatide, sitagliptin. He said he has stopped taking his rosuvastatin for last 3 weeks. Now, there are multiple clues in this vignette even, that the patient has vomiting, pain, abdomen, has increased coloration of the urine, in the background of somebody who is a borderline alcoholic, um, has hypercholesterolemia, is on some medication for the diabetes, and the pain came with having a heavy meal and typical tripoding of the patient. So more points towards an acute abdomen, which is because of possibly pancreatitis. That's what it is. So with that vignette, going into the patient to examine. So you should, sorry, there is a bit of a disturbance in there.
Request everybody to please mute it for others to listen to.
Thank you.
Yeah.
So basically, just as a point to go to examine the patient, you should make sure that what you are going to examine. This patient has pain abdomen. Your examination should focus on the abdomen to start with, not neglecting the other system though. But there is something wrong with the abdomen that you need to have a look. Okay. So the examiner will be very cautiously looking at your examination style to how you examine the abdomen. That is the money here in examination, right? So make sure that you do things that you know how to do it. Like if you are trying to palpate the liver or palpate the kidney or palpate the spleen, do the way it should happen. If you are not sure how to do it, don't show that you are trying to do it, okay? Because that gives a very bad impression if you're doing something wrongly. And if the examiner or caught you doing something in a wrong way, then probably passing that station will be very difficult. So my take on that is examine thoroughly, know the examination in and out, how to do, what's the exact way of examining the abdomen or any system, but don't pretend to examine when you don't know what you're examining. Okay, that is a very, very important thing. Like for example, people put a stethoscope on the abdomen to hear for the bowel sounds, but you need to justify why are you doing it. Okay. So in that way, it's very important to justify each of your action, number one. Number two, bedside etiquette. If the patient is in pain, there's no point pressing on the abdomen. Just ask the examiner, I think the patient is in discomfort. Are you okay still for me to examine the patient or examine the abdomen? Probably the answer will be no, no, you don't need to do it. Okay. So make sure that you show your concern or empathy towards the patient and make it or vocalize it to the examiner so that the examiner knows that you are concerned about the patient, right? So do not examine a patient who is in pain, who is in discomfort. So in that case, you should prevent that, or you should not jump in pressing on something or trying to listen. Okay, there is no shortcut to it. If the patient is not allowing, if the patient is in pain, just tell that I'm not able to examine the patient is in discomfort, he needs pain relief before allowing me to have my examination. So this is acceptable in the exam for you guys to tell it. In fact, it is expected from you guys to utter that you are not able to examine the patient because he is in discomfort or he is in pain, right? Okay. So in this case, you have a patient who has a pain abdomen with yellow discoloration of urine. You know it is possibly something related to the gallbladder, possible hyperbilirubinemia because of a obstructed gallbladder causing pancreatitis. You make a diagnosis in gross sense that this is what it is, but don't get fixated on it, okay? There may be other causes of jaundice and pain abdomen. So always keep your differential broad, but at the same time, you know that probably 90% this is what it is, right? Always keep your differential broad. So the opening question here is, what is your differential diagnosis, okay? So don't talk about other things like, oh, I have a 51-year male came to the hospital 10 days ago, blah, blah, blah. You don't need to tell all of this, just an opening statement that 51-year-old male came with pain abdomen 2 days back to the hospital, now has signs of obstructive jaundice or signs of jaundice in the background of these are the illness, and my differentials are. So 2 line about the opening statement and straight away jump into the mother question. What is there? The main question. So my differentials are like, so you can always classify your answer depending on how you take it. So there are various ways of classifying the answer, but always start with the best possible answer. You think it is pancreatitis, then talk about it. So my differentials are possible pancreatitis. The other causes may be other vascular causes such as a mesenteric vasculitis or mesenteric ischemia. I cannot rule out an infectious cause such as a cholangitis or cholecystitis or colitis. There may be some drug-induced causes such as drug-induced pancreatitis or hepatitis. In this case, though unlikely, but other neoplastic causes can be considered, which includes a perforated colorectal mass. The patient may have inflammatory bowel disease or may have some other traumatic causes because he had ongoing vomiting, which includes a Boerhaave type of syndrome. There may be some atypical presentation of pain abdomen, which likes very unlikely, but it can be due to idiopathic purpura or Mediterranean fever. So in that case, you talk about the most probable diagnosis to start with, and then downgrade your differentials. Of course, mentioning that this is very unlikely, this is very unlikely, but this gives an idea to the examiner that you know about the things, right? But definitely do not miss a pancreatitis, a cholangitis, a perforated viscous. These are the most important things that they want to listen, okay? Rest of them are okay, but definitely do not miss on the main differentials here. Okay, so then the vignette progresses. As you said, pancreatitis, they will go into pancreatitis. What is the possible causes of pancreatitis in this patient? So it is important to look at the initial vignette. If you think pancreatitis, think of the cause of the pancreatitis, right? He drinks a bit. He has hypercholesterolemia. He's a type 2 diabetic patient, right? And there are some drugs that can cause possible pancreatitis. So in this case, what are the possible causes? It can be alcohol. It can be the anti-diabetic medication, the sitagliptin or the exenatide can cause that. Obstructive or mechanical causes, which includes the gallstone or biliary tract disease. Usually they don't show you the imaging in the beginning, but as the limitation of a web-based telecast here, I have to show you the imaging, but they can tell you about the ultrasound finding, or they may ask you a question, what other investigation you want to know about, right? In this case, possibly an ultrasound you need to know, or possibly the bilirubin level or the liver function that you want to know. So tell 2 or 3 investigation that you want to know. If they ask you a question, what other investigation or what other things you want to know. So in that case, don't give them a shopping list saying that, oh, I want to know the hemoglobin, white cell and all those things. Just focus 2 or 3 questions. Like, I want to know the ultrasound finding if it is being done. I want to know his bilirubin level and other liver function test if it is not given to you in the beginning. So 2 or 3 focused question, right? So that will give you a more or less the diagnosis what it is. So going to the question again, what are the possible causes? So alcohol, anti-diabetic medication, gallstone or biliary tract disease, and hyperlipidemia. These are the possible causes of pancreatitis in this patient. Now they will ask you, once the diagnosis is more or less fixed, they will go for further management, which includes the investigation. So they will ask you, what specific investigation will you send for this patient to delineate a diagnosis, right? So just make sure that you listen the question carefully. They are asking about specific investigation to look for the diagnosis, right? So in this case, start always again, classify your answer, whatever the question is. So investigation, blood investigation, imaging, and other septic investigation or other septic workup. So these are three major thing that you usually send for a critically ill patient. So the blood investigation, full blood count, looking for white cell count to look for signs of inflammation. So always try to rationalize your investigation. Why are you sending it? So full blood count, looking for white cell to rule out inflammatory or infection. Renal function test and electrolytes to look for any dyselectrolytemia such as hyperkalemia or hypomagnesemia, hypocalcemia associated with pancreatitis. Lipid profile to look for triglyceride level. Then liver function test to look for presence of hyperbilirubinemia and the breakdown of the bilirubinemia, whether it is direct or indirect. And I will send for serum amylase and lipase to rule out any pancreatitis or any chemical marker for pancreatitis. In this case, I will send blood cultures to make sure that there is no associated infection that we are missing out. I'll send a blood gas to look for acid-base status and electrolyte abnormalities as a point of care test, which I can get quickly, and also to look for the lactate level to rule out any other causes of acute abdomen, in this case, specifically mesenteric ischemia. Now, it is a pain abdomen on the right side. Cardiac causes are very unlikely, but in my practice, I usually send a troponin in this case because the patient is a diabetic patient. We may have ruled out a occult cardiac event in this case, which may not be the cause of the pain abdomen, but it may be associated because he is a high risk case. You can tell about that. Definitely to send a serum ketone because if there is some acidosis or acidemia, you can tell that whether it is a ketonemia causing that. Then these are the blood investigation. The imaging, I would look for a chest X-ray to rule out if there is any other associated chest finding, which includes a pneumonia or pleural effusion that can be associated with pancreatitis. As I said in the beginning, ultrasound abdomen to look for any biliary pathology and also to rule out any other causes such as calculus or acalculous cholecystitis, cholelithiasis, or any hepatic lesions that can cause such liver derangement. I would look for a CT abdomen once the patient is stabilized. But again, that is a bit of a tricky answer. They can dwell into why you need a CT abdomen at this case, at this scenario. So you need to have a prepared answer for that. So I would ask for a CT abdomen to look for any other associated abdominal pathology, which may be a pyelonephritis, which may be a perforated viscous or mesenteric ischemia when the patient is more stabilized. So that should be the ideal answer. So the bottom line of that is when they ask you about investigation, always classify the investigation, talk about the rational ones, giving a reason for most of it. Doesn't have to for every of the investigation, but most of it, looking for like that. Okay. Now we need further progresses. So you has shown the ultrasound picture, which I have done it already, and the laboratory values. Whatever abnormalities are there in the laboratory values, you may be shown that with a printed paper saying that these are the laboratory value. As you have asked about the ultrasound, this is the ultrasound image of the patient. What are the abnormalities? Now, because we are going more and more ultrasound based care, and it is getting to the extent that it is a standard of care, you are expected to know the abnormalities that you look for in a gallbladder pathology, such as what constitutes the signs of cholecystitis, what constitutes the signs of pulmonary embolism, what constitute the signs of other ultrasound, like a pneumothorax in an ultrasound. So you're expected to know the bare minimum of that, right? They can ask you about what are the signs of abnormalities that points towards the gallbladder pathology in a point of care ultrasound. So what are the signs, what are the abnormalities can you see in this film or in this sequence of images that they may show you at the bedside, right? So you can say that it is a moderately distended gallbladder that I showed you earlier with thickened gallbladder wall. There are hyperechoic shadows in the lumen of gallbladder, signs of cholelithiasis with gallbladder sludge, and there is some pericholestatic, cholecystatic, perigallbladder fluid. Sorry. Now they can ask you what are the signs of acute cholecystitis in ultrasound, as I said. So definitely presence of a stone, that is cholelithiasis, which is the most sensitive sign. There may be sonographic Morpheus sign. When you press the probe, you'll have pain. The gallbladder wall may be thickened more than 3 millimeters. Somewhere it is more than 5 millimeters also. The presence of perigallbladder fluid, and there is presence of gallbladder distension and sludge. Any of those 5 findings they will be asking about. Doesn't have to be very accurate, but at least they expect you to have a gross idea about a distended gallbladder with gallbladder, perigallbladder fluid, and presence of sludge or stone. These are the important signs to look for, right? Okay, because there may be a case where the patient will be coming late in the night, 9 o'clock. We may not have a person to do an ultrasound or a technician to do an ultrasound. Then you are the only person who can do an ultrasound in the ICU. And everything suggesting towards a gallbladder pathology. And if you can put a probe in and see something abnormality qualitatively, saying that there is a gallbladder pathology, then that robust make your diagnosis more robust. Okay. Now, what next question? What is the above laboratory and ultrasound finding? Based on that, what is your current provisional diagnosis? So just name that straight away: acute pancreatitis, possibly due to gallstone with the associated cholecystitis and or choledocholithiasis, but that needs to be ruled out with for further investigation. Now, I talked about the CT abdomen. If there is a pancreatitis, they most probably will ask about the timing of CT abdomen. What are the indication of CT abdomen? This is a very important question there, right? So what are the indication of CT abdomen in pancreatitis in initial phase, right? The initial imaging of acute pancreatitis, when the diagnosis of acute pancreatitis is not clear, the patient has hyperamylasmia, severe clinical pancreatitis, abdominal distension or tenderness, fever ongoing more than 102 degree Fahrenheit, and leukocytosis with detection of complications, right? There's a second indication. If the Ranson score is more than 3 or the Apache score of more than 8, the patient who fails to improve after 72 hours of conservative medical treatment, or if there is an acute change in status such as new onset fever, unexplained pain or shock after the initial success of therapy, the patient deteriorates. So these are the major reasons why you will have an initial CT scan in acute pancreatitis, because we all know that the pathology or pathophysiology of pancreatitis is such that the necrosis and everything becomes more clearer later towards the week rather than in the initial phase. But if any of these are suspected, then you go for an initial CT or CT of the abdomen, right? Okay, so this is the important question there. Now the vignette further progresses. They will show you the CT images, the ultrasound report, signs of acute cholecystitis in the report with cholelithiasis. There is intrahepatic biliary dilatation with feeling defect identified on the CBD. This is the printed report that is being shown to you. Now the question is, what is the next step of management of this patient, right? So in this case, you have suspicion of intrahepatic biliary dilatation with a feeling defect in the CBD. The next investigation will be correction of the cause, which is MRCP followed by ERCP, or can consider ERCP directly, depending on the proceduralist choice, depending on the availability of the resources, whether they go stage wise MRCP then ERCP, or straight away ERCP, depending on what you do in your practice. Now, what are the indication for ERCP in acute pancreatitis? This is again important because these are the one of few of the correctable cause for a pancreatitis where you need to fix the issue of the source of pancreatitis. So the indication for an ERCP in acute pancreatitis are gallstone pancreatitis with cholangitis, common bile duct obstruction, visible stone on the imaging, dilatation of the common bile duct, or worsening liver test without cholangitis. So these are the 4 possible indications for an ERCP. Again, this is very variable depending on who is doing the procedure and what is the perception of the person. But these are the standard or box standard indication for ERCP in acute pancreatitis. Now, what is the ideal time from ERCP? The next question. It is ideally within 24 hours of presentation. That has to be done because it is a correctable cause, and delaying the procedure may cause further problematic situation or further worsen the patient situation. But again, this is based on how stable is the patient, how much you have resuscitated, and whether it is safe for the patient to go for the procedure or not, right? What is your nutritional plan again for this patient? So pancreatitis and nutritional plan go side by side always, right? So make sure that you are very, very thorough about the ins and outs of nutrition plan in pancreatitis. So I'll go very quickly in there. So again, if there is a nutritional plan, you talk about the target, you talk about the route, you talk about the timing and the monitoring part. Make sure you utter all those words because these words does carry mark, right? So timing enteral should be started early within 24 to 72 hours of admission. In case of intolerance to oral feeding, then you go for enteral feeding or a tube feeding like a nasogastric or nasogeographic feed, depending on how the tolerance is. But you can wait for 24 to 72 hours to see how the oral tolerance is. Now the route, as I said, the oral feeding as soon as clinically tolerated. But that is more of a consideration in mild pancreatitis. In case of severe variety, the oral tolerance may not be there. If inability to feed orally, enteral nutrition is preferred over parenteral nutrition. That's an important message that you need to pass on to the examiner. The nasogastric route is preferred, but nasogeographic can be considered if there is intolerance to nasogastric feed. Parenteral nutrition should be considered if unable to feed enterally by day 5 due to severe intolerance or contraindication for enteral feeding, right? Now, type and target, as we said earlier, 25 kilocal per kg per day, 1 to 2 gram of protein per kg. Monitoring is done for tolerance like gastric acidical volume and intraabdominal pressure, because overfeeding can raise the intraabdominal pressure, causing further worsening of the patient's other organ dysfunction. So this is important monitoring. You need to talk about gastric acidical volume, though it is not very robustly backed up by evidence, but in my practice, whatever you do, you need to tell and definitely mention about intraabdominal pressure. Okay. Now, how do you evaluate severity of acute pancreatitis? Now, going into the limb of pancreatitis, how do you evaluate the severity? Again, classify. That's how you do the answering. Clinical, organ specific score, and imaging score, right? Clinical scores, Ranson's criteria, Apache 2, biceps criteria. Organ specific is the SOFA score. Again, this is a clinical and parameter based classification. And the imaging score is the CT severity index or Balthazar score. Important to know about Branson's criteria. What are the component of that? You are expected to know about it. And the CT severity index, you are expected to know about it, because they will show you a scan and tell you in what severity the scan falls, depending on what finding you have. But I think that is more of a mark scoring phase of the exam rather than passing the exam. Okay, so you need to know about these two or three scoring system. Now, again, what are the complications of acute pancreatitis? Classify your answer. Local complication, systemic complication. Local complication, necrosis, abscess, cirrhosis, pancreatic ascites, clinic and other arterial aneurysm, aneurysmal bleed, catastrophic bleed. Systemic complication, each system can have its complication. Respiratory pleural effusion, atelectasis, secondary infection, aspiration, stress cardiomyopathy, shock, hypovolemic or vasoplegic, renal, again AKI, dyselectrolytemia, metabolic, and all of that. So just classify local complication, systemic complication. You can tell early, late, medium term also. But if you need to have a basis of answering, that's what the examiner looks for. Not randomly saying that, oh, abdominal compartment syndrome, infection, all those things. Yes, all of those points are correct, but it doesn't sound good when you're answering haphazardly. You need to have a format of answering, right? Now they can show you a CT scan and tell you, please interpret the CT scan. This is very important because any CT like abdominal CT, head CT, chest CT, these are very, very much questions that are asked in the exam. If you are doing well, they will show you a running CT scan and ask you to interpret what it is, right? So in this case, based on the imaging that we had earlier, it looks like a severe pancreatitis. Sometimes they can show you a world of collection and they will ask you, what is this? This is a pseudo pancreatic pseudocyst. And if you answer it correctly, how do you manage a pancreatic pseudocyst? Again, your answer will be expectant observation to start with. If it is not resolving, or if it has complications such as obstructive symptoms, then you go for intervention such as endoscopic or surgical drainage. Okay. I think I have finished this case. We deliberately kept it small because of the time constraint. So Tapas, I'm done with the case.
Yeah. So Dr. Abram.
This is a straightforward compared to the other case, the first one. This has only one system issue, the abdomen, and we have to sort out the abdominal issue. And from there, the examiner can take the discussion anywhere. It can be nutrition, it can be a surgical abdomen with peritonitis, it can go anywhere. But it is limited to that system, and the nutritional part. Unlike the first case was a classical long stay chronic patient in the ICU, which is a lot of things to discuss in management, long-term care, all of those things. So the basic principle in this case is also the same as the first one. Okay, here also we are trying to see whether you are a good, safe consultant when you complete the exams. So your presentation has to be crisp, to the point, organized. Your thought process also, to get that thought process, you have to do more bedside teaching. I keep harping on that, bedside. Get your consultant to do the bedside case presentation for you. Otherwise, the questions for this case is going to be standard. Your differential diagnosis for a patient who comes with this sort of pain in the abdomen, give it in a systematic way. Then your working diagnosis. How do you confirm that working diagnosis? What are the investigations you would do? Again, give it in a systematic way, and give a reason for why you have chosen that order. Why I'm saying that is a patient who comes with pain abdomen within 6 hours coming into the ICU, a lot of candidates will say CT scan. And then the first question that the examiner is going to ask is, why CT scan? So to diagnose pancreatitis, okay, and there you have already dug your grave, okay, clearly showing that you do not know when to do the CT scan to diagnose it. So you should be very clear. Don't jump. Don't be too anxious in your exam tension. Don't give the wrong. It's not the wrong answer. It's a wrong answer for that particular moment. So think properly before you do it. And this being a straightforward case, I think you can, in fact, lead the consultant to your area of interest. If you think you are better in nutrition, bring in a little bit of then, nutrition. The exam will say nutrition. So when will you start nutrition? How will you start nutrition? Go down that path. Okay. So I think this is a straightforward case, easy. This is a case where you can, score a lot of marks if you present properly.
Yes, yes, totally agreed. And one more thing to add, as it is easy, so maybe the number of correct responses the examiner wants is also high. So if you
definitely, if you do, this is an easy case. If you make a mistake in it, they'll say, "Oh, this person doesn't even know the basics." That's a problem. And as you said, examination. Okay, when you are examining the patient on the bedside, the examiner will be observing. All of you all are doing a super specialty program. You would have finished your MBBS, you would have finished your postgraduate degree before taking up this. If you do not know how to examine the abdomen properly, not only examine, any system for that matter, okay, you will be marked down. I'm sorry to tell you that. Especially, this case has not been put. Where the problem arises, I've seen, is when you get a neurological case, a patient with neuromuscular weakness. I see it's utter chaos when it comes to examination. Please know how to examine a patient with GBS. Okay, pulmonary system. How will you assess whether the patient is going to go in for respiratory failure? When should you intervene? How are you going to look for a weakness of your respiratory muscles? You should need to know that. Okay. You have come, this is a super specialty, because you can't say I only know how to do interventions. I do not know basic, clinical examination.
Sir, I would be like, no, having this concern nowadays, like, no, the bedside teaching and the clinical examination is dying somehow. Like right now, we are also facing the candidates. They are more of dependent, like, no, let's wait for the CT scan rather than like, no, like going for a like, no, clinical examination.
That is corporate medicine. That's why.
Yes.
Basic. I think in medical school, college, we are still clinical.
Yes.
And only then Dr. Divedia will be able to tell us better on that. I don't think.
No, he has left because of some urgent.
No. Okay, not an issue. I think we need to still preserve the clinical skills, because we have to integrate everything together. It's not just investigations. I'm not saying that the American way of doing medicine, like investigations and then fall back on your clinical skills, is wrong. And that the British way, where you depend on your clinical skills and then choose your investigations, is correct. I'm not saying that you need both. A lot of patients, you have to put both together to come to a diagnosis. So you should not lose your clinical skills too.
Yes. And that's the message for the first year, second year DNB as well as DM candidates or IDCSM candidates, because there are many candidates who are not only DNB SS practical exam goers. So for them, the take-home message, it's not never late. You have to start this bedside examination as well as all these appreciating the clinical signs at the bedside, rather than only very upon the lab results or investigation results. Yeah. Thank you, sir, for this very valuable inputs, and that's the reason why we want you to be in our forthcoming all these initiatives. Thank you, sir, for your.
Thank you very much.
Yeah. So
Thank
any
you,
queries?
Thank you.
Yeah, Dr. Sanant.
Yeah, I don't think there is a query in the chat box, so I think we are running more than 2 hours, Tapas, and we should.
Yeah. So just before concluding, thank you, Dr. Sanant. Thank you, Dr. Abraham. Thank you, Dr. Divatia, sir. He has left because of some commitment. The next mock test we are having on September 26. That would be again having very interesting cases, as well as the table viva, as well as all these critical appraisal and communication stations. So please join on those days. And also we are having few other things like this. Today we missed the table viva, the image as well as would be definitely doing that.
Before you close, can I just one thing that I can add about the table viva?
Yes, sir.
You had put a lot of ECGs,
right,
which
sir.
we are supposed to discuss. I would like the candidates to know that the basic ECGs, especially arrest rhythms or peri-arrest rhythm ECGs, you cannot miss. People fail on that. If you miss your arrest or peri-arrest rhythm ECGs, shockable versus non-shockable, it is not pardonable as a critical care. Because the last exam, I remember we had as an examiner, we had a big debate. The candidate did overall quite well, but did not pick up a VFib strip which was given to him. Okay. And so his whole management went haywire. He didn't shock the patient. So the examiner is saying, this is bread and butter critical care. If he can't pick up VFib and shock, how the hell am I going to pass him? No. He needs to fail. He needs to redo the whole thing. So that is a big debate. But the chief examiner, stepped in and sorted it out. But so be very careful with that. Most of us will be very good with complex ECGs. Okay, all that they will say, but the basic ones, even if you miss the complex ECG, no one will fail you. But arrest and peri-arrest rhythms, if you miss, you are in deep problem.
Yes.
No, I agree completely. You cannot miss a arrest or peri-arrest rhythm. I will not pass the candidate.
Correct.
So, you have no right to say that you are an intensivist. At least.
Correct.
Yes.
Correct.
Yes. Thank you, sir, for these wise words and motivating words for our trainees. And thank you all the delegates for sparing their 2 hours, 15 minutes or so. And we would be again having a similar classes or more interesting than this class in the next upcoming weeks. Thank you all. Yeah.
Thank you. Thank you and good night.
Good night.
Thank you.